Hello students, in today's session we'll be discussing about rheumatoid arthritis. One of the commonest immune-mediated arthritis with profound deformities that you'd see is rheumatoid arthritis. And again remember, rheumatoid arthritis is a multi-system disorder. It's a chronic progressive disorder which has to be identified fast and controlled by using immunomodulatory therapy. So, by definition, rheumatoid arthritis is a chronic, inflammatory, symmetrical polyarthritis with the deformities. Very importantly, if not treated early, they do have permanent deformity. So, the joint, the cartilage is also involved. Again, these patients have a lot of systemic features also, which has to be looked into it whenever we look at these patients. And as I already mentioned, early diagnosis is the key, and aggressive treatment with DMARDs or biologicals, which will prevent the deformities from happening, is that what we have to understand. So what are the classical clinical features all of you would have seen? Usually between the age of 25 to maybe 40-45, you would find there. Usually you don't find it above the age of 60, usually plateaus there. Most important features, they will have symmetrical small joints of the hand involved. That is very important, symmetrically, and they have the most important morning stiffness lasting for more than 1 hour. So, which will be relieved on activity. Usually, as we said, it is polyarticular, that is more than 5 joint areas involved. Sometimes you could have oligo. Very rarely monoarticular form, you would get it. Sometimes these patients may not have joint, they may just come with systemic manifestations that you could see there. What is classical about the rheumatoid arthritis is the involvement of the hand joints. The distal interphalangeal joint is paired. That is very important, one more feature. PIP, metacarpophalangeal, interphalangeal, the wrist joint, the elbow joint, all of them are involved, but then the distal interphalangeal joint is paired. The most common joint involvement, if they ask you, in the frequency, wrist is more common, followed by the metacarpal, followed by the proximal interphalangeal joint that's there. Distal interphalangeal joint involvement would mean either it's a psoriatic arthritis or an OA that's there. Also, they can have flexor synovitis of the tenosynovitis of the hand that could be seen, which can decrease the range of movement, can cause deformities and can cause trigger finger that's there. Also, you could have various tendon ruptures that could happen. The most common is the FPL, that the flexor pollicis longus, which can result in certain deformities. And as the disease progresses, you have the inflammatory pannus which goes and erodes the joint, and the patients will develop the classical deformities which you see. So, the common deformities are the ulnar deviation, you have the swan neck deformity, you have the botanier deformity, the Z deformity, the piano key deformity that you have. In the foot, the metatarsophalangeal joint can get involved. You could have the classical hallux valgus can be there. The mid-tarsal arthritis, what we call it as the flat feet, pes plano valgus, that's what is the classical deformity that you could get. Also, you could have the large joint involvement. So, you can have the elbow involvement, the hip involvement, the knee joint involvement, usually less common. Again, the disease can involve the other joints, that's the spine. The most common structure that is involved in the spine is the atlantoaxial joint. It results in C1, C2 subluxation because the transallar ligament, which is holding the dens odontoid process onto the atlas, that gets degenerated, so the dens falls back and causes compressive myelopathy. So, the patient can have paraparesis also. Thoracic and lumbar spine is very rarely involved. Smaller joints like the cricoarytenoid joint, the sternoclavicular joints can also be involved in that. Extra-articular manifestation is something that we have to look for. It can involve every part of the body. So most of the patients can have fever, fatigue, weight loss that can be there. Ocular involvement in the form of keratoconjunctivitis sicca, episcleritis, scleritis can be seen. It can have scleromalacia perforans also. Orally, they can have xerostomia and periodontitis. In the lung, they can have pulmonary fibrosis, pulmonary nodules, and interstitial lung disease and pleural effusions. You have a syndrome called as the Kaplan syndrome in the lung, where you have a rheumatoid nodule with pneumoconiosis, most often coal workers. In the cardiac, again, it can produce pericarditis, it can produce myocarditis, it can produce mitral regurgitation, arrhythmias, and it's a pro-inflammatory condition, so ischemic heart disease is common. In the kidney, it can produce membranous nephropathy and secondary amyloidosis. Hypoadrenism, hypogonadism can be seen, osteoporosis, vasculitis. Neurological, it can produce polyneuropathy, mononeuritis multiplexa, and compressive myelopathy. Anemia of chronic disease is common with them. You can have anemia due to a variety of other causes. Could be due to GI bleed, could be due to drug toxicity. They can have Felty syndrome, that is a triad of splenomegaly, granulocytopenia, and deformed rheumatoid arthritis. These patients are prone to develop large granular lymphocytic lymphoma and leukemias also. The skin, they can get ulcers, they can have purpura, they can have pyoderma gangrenosum and a rheumatoid nodule. Rheumatoid nodules are much bigger in size and they are usually painful. Can be located anywhere. It can be seen in the skin, subcutaneous tissue, it can be seen in the muscle, in the lung, in the solid organs it can be seen, synovium it can be seen, and it responds well to methotrexate that you would see there. These patients can have one of the causes of PUO that's there, and cachexia can also be seen. Important problems with that is that sometimes these patients can have a systemic onset of the symptoms itself rather than the arthritis coming. But majority of them will have arthritis plus systemic features that you could see. So in all patients with rheumatoid arthritis, we are expected to rule out all these systemic complications also. Patients can manifest with emergencies like a GI bleed or an atlantoaxial dislocation or a scleromalacia perforans can be seen. Nodules, as I told you, so it is usually seen in almost around 40% of the patients you do get it. And it's located usually in the extensor aspects in the Achilles tendon, but as I told you, it can be located in the systemic also. Methotrexate, which is used for the treatment, can also accelerate the growth. That is one thing that you have to remember. Again, a common difference they ask you is between rheumatic and rheumatoid nodule. Rheumatic nodules are very small, pea size. They are painless, located only in the scalp, in between the scalp, the scapula, on the occiput, extensor, and they are evanescent. They are 100% associated with carditis, response to steroids and NSAIDs, whereas rheumatoid nodules are associated with arthritis and they cause more deformities that could be seen there. Sjogren syndrome is very commonly associated, so they can have xerostomia and keratoconjunctivitis sicca. Patients' lung involvement is something that we should always monitor these patients for, because rheumatoid causes fibrosis, methotrexate also causes fibrosis, so the patients can come with a restrictive lung disease pattern that we'll have to look for. The cardiac manifestations, though not very common, seen in less than 10% of these patients, but these patients have a very strong risk factor for atherosclerosis because the disease itself is inflammatory, so they can develop MI, they can have peripheral vascular disease, gangrene, strokes, and they can also develop cardiomyopathy. Mitral regurgitation is one thing that you can always get. Vasculitis, as we said, it's an inflammatory condition, so which can cause major organ involvement, it can cause ocular involvement, skin lesions like petechiae, purpura, gangrene, etc., and neuropathy like the mononeuritis multiplexa that you see. Leading cause of death is the cardiovascular itself, because as I said, the risk factor for atherosclerosis is doubled. Patients with the rheumatoid arthritis per se or on treatment are prone to develop osteoporosis. So again, almost 2.5 to 3 times higher risk of osteoporosis. So because of that, they can have fractures and hip fractures, etc. So it is due to inflammation, osteoclast activation, or glucocorticoids also. So these are the clinical features. Let's briefly discuss the epidemiology. So again, 1% of the global population do have it, more common in females, almost 2.3:1 ratio in males to females. And estrogen may contribute to the development of the disease. However, the pathophysiology is unclear there. Genetic consideration, almost 40 to 50% of heritability is seen, and the HLA association is the HLA-DR B1 gene is the highest risk factor that's there. Especially in these patients, the anti-citrullinated protein antibody is the important feature that you would see there. The non-HLA genes are the PTPN22 and the PAD14 are important risk factors that you see. Epigenetic mechanisms like DNA methylation, microRNAs and other important epigenetic influences have been proven as the key to the development of rheumatoid arthritis. Environmental factors, the most important one is smoking, is a direct risk factor, especially in patients who have genetic predisposition. Microbial dysbiosis, especially one organism what has been studied is the Porphyromonas gingivalis. This is from the oral cavity, has been associated with that. Other microbes are like Epstein-Barr virus also has been studied, but actually it's not been proven very clearly. Now when we look at the entire pathophysiology, this is an inflammatory, so synovial tissue which is inflamed results in formation of pannus. Pannus behaves like malignancy and that produces a joint destruction. So both the T cells and the B cells are activating. So you have a lot of inflammatory cytokines as well as antibodies which will cause osteoclastic activation which results bone resorption and joint erosions. And the inflammatory mediators like TNF, interleukins 1 and 6 are the ones which are strong mediators that you would see there. Again, as we say, it is an autoimmune disease. So there is a breakdown of the self-tolerance and the antibodies like the rheumatoid factor and the ACPA levels, we see it there. Environmental trigger like smoking and infection is there, but there is a genetic predisposition which results in T cell activation and that will result in inflammation and joint destruction. Cytokine activation resulting in T cell as well as B cell mediated activation. Osteoclast activation resulting in bone damage that you would see there. So if you look at the general part, so genetic and environmental factors would act through various receptors and the CD80 and CD28 is the primarily, and you have the T helper cell 1 getting activated releasing interferons, tumor excess alpha and lymphotoxin B, and the THC 17 getting activated which releases interleukin 17A, interleukin 17F, TNF alpha, IL-6 and GM-CSF. And these are going to recruit the particular cells and they are going to have multiple modalities of action that which results in the inflammation that's there. So we can target at any point, we can target the TLF, we can target the interleukins, and that's how we can control the variety of symptoms as well as the disease progression. Now coming on to the diagnosis, so you have the ACR-EULAR criteria given by American College of Rheumatology and European League of Rheumatology. So joint involvement, serology and acute phase reaction and duration of symptoms. So joint involvement, if you have one large joint, the score is 0, 2 to 10 large joint, the score is 1. But if you have 1 to 3 small joints, remember MCP, PIP, thumb, MTP and wrist, these are the small joints, you directly get a score of 2. And if you have more than 4 to 10 small joints, then the score is 3. More than 10 joints, the score becomes 5. So polyarthritis will have a higher score that you have here. Negative RF and negative anti-citrullinated peptide antibodies gets a score of Z. Low positive gets a score of 2. If it is a high positive titer, it gets a score of 3. Normal CRP and ESR gets a score of 0 and abnormal or the elevated gets a score of 1. Duration less than 6 gets a score of 0 and duration more than 6 weeks gets a score of 1. Now based on this, we classify the score, the higher the scores, any score possibly more than 5 and above would strongly suggest a diagnosis of rheumatoid arthritis that we have in these patients. So if you look at the antibodies which are present, so rheumatoid factor was the good old antibody which was done routinely, but we remember 30% of rheumatoid arthritis is RF negative. And again, rheumatoid factor does not correlate with the disease severity, nor it correlates with only rheumatoid. More commonly seen with Sjogren's, mixed connective tissue disorders. It could be seen in normal population, it could be seen in almost 5% healthy individuals, as well as aging it could be seen. So rheumatoid factor could be of various types, so IgM, IgG or IgA, all of them could be seen. But more commonly, please remember Sjogren's, SLE, cryoglobulinemia and chronic infections, it would be seen there. Anti-citrullinatic peptide antibody, that is something which is more specific, almost 95%, and it is present much earlier that you would see there. ANA may be positive in almost 30% of these patients. ANCA can be positive in a small group of patients. Anti-MPO and anti-PR3 can be positive in them. Synovial fluid in these patients usually will have 5,000 to 50,000 cells. Neutrophils are the predominant there. Main thing is to rule out infection or a culture or a crystal arthropathies. Joint initial changes may not show much. You may have to do the ultrasound to see the synovial thickening or the effusion. Later you would get the classical deformities, the erosions, the joint space loss, subchondral erosions and deformities can be very classically seen, involving the specific joints, the MCP, PIP and the MTP joints, especially this fifth metatarsophalangeal joint is classically involved. MRI can detect the deformities a little more earlier, but what has come up now is the ultrasound of the joint which can be done bedside. Clinical course, the rheumatoid arthritis usually has a progressive course. Sometimes they can have remission and resolution that could happen there. Disability will progress, so we have to start the treatment as early and start DMARDs as soon as possible, that is there. So the good old steroids, NSAIDs are only temporary relief. The mainstay of therapy is the DMARDs, and now you have the biologicals that are there. Whenever there is an acute flare, possibly we'll have to use steroids as a mainstay therapy that is there. Now coming on to the main drugs that we have in our armamentarium, starting with the first one, that is the hydroxychloroquine. We give it around 200 to 400 milligrams daily, that's given. The important problem that we'll have to see is the bullseye maculopathy and sometimes cardiotoxicity. So you will have to monitor these patients' eyes every year, okay, to look for that. And if you have a suspicion of that, then you do have to do a OCT for that also. Next drug which is commonly used is a methotrexate. Now it's given weekly. We give a dose of maybe 5 milligrams or 5 to 25 milligrams weekly we give it. That is the dose. You can give the same dose subcutaneous also. Important, methotrexate if you are giving, you will have to follow it up by folic acid. Either 1 milligrams daily or 5 milligrams twice a week you have to give. Don't give it on the same day of methotrexate. Important side effects, hemolytic anemia, myelosuppression, pulmonary fibrosis, and this is not being used in pregnancy, you cannot use it. Also it can produce ILD also, so we will have to monitor the LFTs, the complete blood count, the respiratory, and also look for infections. Sulfasalazine, though not a very commonly used in rheumatoid arthritis, but you can use 500 to 1500 milligrams. Important side effects of sulfasalazine again is hemolytic anemia and granulocytopenia, which has to be monitored. The good drug that has come is your leflunomide. So leflunomide is an orotate inhibitor, orotic acid mechanism that's there, 20 milligrams per day. Hepatotoxicity only has to be monitored and it cannot be used in pregnancy. So these are the main drugs from the DMARDs that have been used. Coming on to the next category of drugs, what is the biologicals that we have. The main drugs that we have under that is the TNF-alpha inhibitors, and the drugs that we have under that is the infliximab, etanercept, adalimumab, the golimumab and the cetrorelizumab. Now these have to be given parenterally, either subcutaneous or intravenous. TNF, infliximab, we give 3 mg per kg IV on weeks 0, 2, 6 and then every 8 weeks that have been done. Now the important thing about these biologicals is they can cause severe immunosuppression and flare up the infections. So tuberculosis has to be ruled out, tuberculosis screening and LFT monitoring has to be done. The etanercept has to be given 50 mg subcutaneous weekly and later you can change to bi-weekly. Similar reactions can be there. With them, the chance of lymphoma, especially with infliximab, has been reported, however not proven. Adalimumab is 40 milligrams subcutaneously every alternate week. Golimumab is 50 milligrams once monthly, and cetrolizumab is 400 milligrams on 0, 2, 4 and later 200 milligrams every weekly. Chances of infection, tuberculosis screening is mandatory. Coming on to the next drug that we have is the abatacept, where you give 500 milligrams or 750 milligrams. It's IV given. Again, we'll have to monitor for the infections in that. Anakinra, 100 milligrams subcutaneous daily. Again, the infections have to be monitored. The B-cell inhibitors, rituximab, you give 1000 milligrams IV on twice 2 doses, 0 and 14, and later you can repeat it every 24 weeks. Rituximab, again, other than infections, it can cause cytopenia and hepatitis B reactivation that is seen. Coming on to the interleukin inhibitors, the drug that we have is the tocilizumab, 4 to 8 milligrams per kg IV monthly it's given, or saralimumab, which is 200 milligrams subcutaneously which is given. Again, it can cause dyslipidemia and cytopenias. We have to monitor the counts as well as the infections. The oral drugs which have come for the treatment of rheumatoid arthritis and are being used upfront. So the JAK inhibitors, that is the tofacitinib, we give 5 milligrams twice daily, can be increased the dose, or the upadacitinib, which is given 15 milligrams orally daily, or the baricitinib 2 milligrams daily. Monitoring the LFT, monitoring the counts is important. Again, these JAK2 inhibitors have a chance of thrombosis that we have to be kept in mind. So this is what we use routinely. Now, when you say the ACR-EULAR definition for remission for rheumatoid arthritis is swollen joint count less than 1, CRP should be less than 1 milligram, and patient's global assessment scale also should be less than 1 in 0 to 10. And you have a SDI, that is a simplified disease activity index, should be less than 3.3. Only then can we consider it patient to be in remission. So our aim is to achieve remission either by using the DMARDs or biologicals upfront. So that is what we have to use. Again, a combination of DMARDs, a methotrexate with a hydroxychloroquine with the tofacitinib, that combinations 2 or 3 drugs can be used. Please remember, steroids are only for flare and NSAIDs are only for pain relief. Majority of the DMARDs would take at least 2 to 4 weeks to act. So till then you can tide over with NSAIDs that are there. Very, very important, we have to understand that we have to identify this disease, rule out the other causes, look for systemic manifestations and individualize therapy. And these patients have to be on frequent monitoring, monthly blood tests are needed, and adjustment of doses are needed. Most of these patients, if they are young, many of these drugs are teratogenic, so we cannot be used. So we have to be careful during pregnancy, if they are planning pregnancy, etc. They require to be counseled well. And the chances of infections are very high in these patients, so we have to advise them universal prophylaxis. Again, remember, these diseases are going to be chronic diseases. They are going to be there for their lifetime. Though the remission may happen, you will have to tell them that this can be, these medications have to be continued and follow-up is needed. The parenteral ones are a little costly. However, the drug dosages with the time, these cost effectiveness has come. These patients, once they develop deformity, you will have to replace the joints also. So better than that would be giving these drugs that are there. Simple drugs like methotrexate weekly or a sulfasalazine with hydroxychloroquine also controls the drugs, also controls the disease to a very great extent. Please importantly remember, these patients are highly prone to develop vasculitis and strokes and MI, etc. So they are monitoring of the sugars, monitoring of the lipids, monitoring of the blood pressure, and frequent monitoring for the blood counts, etc. are mandatory. Students, in today's session we discussed about rheumatoid arthritis, the pathophysiology, diagnostic criteria, clinical features and management. Early aggressive therapy is the key for the management of rheumatoid arthritis to prevent deformities and prevent morbidity.